Thank you. Thank you very much for asking me to come and speak. So, as I've been introduced, I'm current co-chair of BLS. I work in Scotland, as you'll hear from my accent. I'm actually a physiotherapist by background. So I am a lymphedema specialist working in central Scotland in a clinic. And I also lecture at the University of Glasgow. So I think it always helps to sort of focus before we even start. These are some of our patients who've been very happy to share their story. You can see most of them have got lymphedema. The lady at the very bottom has lipedema rather than lymphedema. But when we talk about compression, these are some of the shapes of the limbs that we're looking at to be trying to apply compression to. I do work in a specialist clinic, so most of the patients that I see are complex. So I thought I'd start I know you all know this, but just as a wee reminder, lymphedema is a failure of the lymphatic system, and the consequences of that are swelling. And it can happen anywhere, but obviously our focus today is on legs. There's a bit of a discrepancy and still an argument going on or discussion going on about lymphedema versus chronic edema and what the two terms mean. And we know that chronic edema means anything that's been there for more than 3 months. Now, when we look at the definitions, we know that all chronic edema indicates that there's a problem with the lymphatics. The lymphatics should be taking that extra fluid away. So if they're not, there's a problem with the lymphatics. So the theory since 2014 actually is that the idea that any chronic edema there is synonymous with the presence of lymphedema. So we can use the terms interchangeably. So lymphedema covers what we used to call chronic edema as well. And when we look at lymphedema, though it's still not covered in many undergraduate courses, we find that nurses at Glasgow don't cover it, the medics don't cover it, it's only if they get a special placement. Me as a physio, we didn't cover it particularly, but actually the prevalence is twice that of MS and similar to Parkinson's, for all that we find that a lot of people don't know much about lymphedema. We know the prevalence rises with age, more common in women. Now, is it more common in women, or is it just that women are more likely to go to a clinic so that they've been counted? We know that it increases more significantly as our age goes. So, by the time you're 65, it's jumped up to almost twice the prevalence. By the time you're over 85, that's increased hugely again. We also know that leg ulcerations present in about 50% of the patients that were identified with chronic edema in one of the studies that was done, and 31% of them had an ulcer for more than 5 years. Unfortunately, still, even though we've got quite a robust referral system in our area, we still find that we get a lot of lymphedema patients that have been living with their condition with no input at all for 10 years plus. 5 years is really common, 10 years is still out there, and you wonder what's happening that that's the case. We know that with obesity, age and cancer, that there's an increased risk of developing lymphedema, and those same factors that increase the risk also increase the complication and negatively impact on how good outcomes might be. Again, just a quick reminder, functions of the lymphatic system, it returns the fluid to the circulation system, so it balances our fluid within the tissues. It mops up proteins, toxins, fats, enzymes, anything like that. And that gives it that boggy, thick feeling rather than just a watery swelling. And it obviously has a role in the immune system. So our patients are more prone to infection or cellulitis than someone living without lymphedema. So when we get onto compression, which is the theme today, it's our mainstay of treatment. Now, we use skincare, we use movement, weight management. These are all very important, but compression, as has been the theme throughout the day, is our friend. It's what we need to get going. And as Kate's just said, unless we can get patients understanding what compression is and why it works and how it works and make sure it's the right compression for them, we're not going to get anywhere. And some of the case studies that I'm hopefully get time to go on to in the end will show that sometimes what the outcome is, it's best for that individual. It's not best for me theoretically. And I think that's quite hard as a clinician to remember, that there's a person attached to these legs. It's not just what we would like to do by the book. We have a whole range of different types of compression that we can use now. But in lymphedema, there's not one gold standard. We're not trying to necessarily get 40 millimetres of mercury. It's a very different thought process to applying compression than it would be in wound healing. So what does it do? It reduces capillary filtration, so it stops some of that push of the fluid out into the tissues. It will hopefully hold that. And by creating a wall, you'll also have an increase in the lymphatic drainage, so it will help push some of the fluid back in. It shifts the fluid into a non or less compressed part of the body, and that's something that's very important for us. For a lot of our patients, we have concerns because they've got maybe bandaging from the base of the toes, and so they end up with swollen toes, things like that. So it's thinking, where's it actually going to? Or we have compression to the knee, and then above the thigh bit's not compressed, so it becomes swollen, a problem. Helps us break down fibrosclerotic tissue, but two of the main things, it helps comfort and support for patients. For some patients, they feel so much better. I think sometimes as healthcare professionals, we worry about putting compression on and that they're going to find it difficult to wear, but actually the right compression for a lot of our patients helps them with comfort and support and helps them restore skin integrity. But it's the balancing everything off, isn't it? So getting the right product for that patient, for that individual, because they aren't just a leg, there's a whole person involved. So we need that comprehensive assessment. I'm going to talk a bit more in a minute. We need accurate measurement. We also take base measurements so that we can follow what's happened with the limb, what's changing with the limb size. But for some people, the change in the limb size is not the important thing. It's getting their shoes on, it's getting into a pair of jeans, whatever. To us, it's the measurements. To them, it's getting that bit of clothing on. Or a lighter leg for stepping up a stair. We look at their skin and the subcutaneous tissues. We need to know about their general physical condition, activity and function. There's no point giving someone a garment that they can't get on. The very best garment in the world is no good to them if they can't actually apply it. What their emotional state is as well. There are some of my patients, one of my ladies who was in recently, when I talked about compression, she was devastated at the idea that the only thing really to manage her legs was compression. That was going to be what she was going to wear. Because in her head, compression was a horrible brown American tan coloured garment that was thick and sort of Nora Batty-like, that would fall down, and that she would have no choice in the colours or the texture of it, and she was horrified by it. What social support have they got? Do they need, like the last case study, have they got a dad in the background who can help them? Is their spouse able to help them? Have they got friends and family? What support do they have? And what do they want? What is their preference? We have one lady who said, and we do get quite a lot of patients that will come into the clinic and say, oh, don't give me compression. I don't like compression. I've had it before. I can't wear it. So they've had the wrong compression. But one of our ladies, her favourite colour is purple. So she challenged, when my colleague went out to see her in the home, she said, no, I'm not wearing compression. I don't like it. And so they had a chat, and she said, well, I'd maybe wear it if it was purple. So, of course, that was a challenge. And some of the companies do purple garments. She got a nice purple pair of socks and she wears them quite happily. So, again, it's what the preference is, what's important to that person. So, knowing the products, there are a huge range of garment companies and they work so hard to get us good products for our patients. And the range of different fabrics, different stiffness, different types of options that we've got is phenomenal. We need to be able to be willing to negotiate and compromise and be flexible. We've just seen a fantastic case study of that. I don't need to preach any more about that one, but yeah, we do. It's not what we want to do. We only see that patient how many times a year? They're living with a condition absolutely every day. So it needs to be something that they feel they can manage. So they need the education and explanations and support that patient. So when we look at our patient in the centre, we've got a whole pile of things that we do, don't we? We've got goals that we need to agree. They need to be realistic and agreed. My goals are not the same as the patient's. We need to know what they want to do, what is important to them. We absolutely need a medical history. I need to think what their actual physical medical history is, but I also need to know what medication they're on, what other operations they've had, where they're coming from. What's their thoughts on it as well? I've had patients who have a tiny bit of swelling and it's huge to them. It's absolutely ruining their life. I've had other people who have legs like this gentleman who are really not that bothered about it. They've only come because their doctors told them to come. Obviously, our notes are a legal documentation, so we need to be on that. And I need to move my slide over, I can't see. We need a clinical assessment. We need to be able to touch and feel and find what's going on with that limb. What do the tissues feel like? What's the heat in the limb? What's the pulses like? What's the circulatory signs? We don't necessarily do an ABPI in our clinic. We don't do them at all. We use the rest of the assessment to give us that information. We need appropriate referral pathways. We're very close to our vascular team, to our TVs. We work closely with our district nurses. Who else do we need? A podiatrists as well, orthotics. There's a whole range of people that we use. We hope to provide a better understanding for the patient. We need to be able to come up with an accurate diagnosis. Why have they got the swelling? Unfortunately, we still got quite a lot of referrals coming in that say, literally, the person's got swollen legs, can you treat them? But why have they got the swollen legs? Has their cardiac status been checked? Have they looked at their renal status? Do we know there's no oncology history? What's actually going on with that patient? And all these things will help with concordance and better self-management. I need that person to be able to take care of their legs. I'm not going to see them every day. I need them to be able to do it themselves. We do take baseline measurements so that we can focus what's happened over the journey. We do need to be careful with that. Some patients become very self-absorbed or upset about what their limb volumes are. So we try and modify that. And again, it depends on what goals we're working. Some of our palliative patients, we wouldn't even take particularly detailed limb volume measurements because our goal's not about limb volume reduction, it's about providing support and comfort. So they need to be patient-centered, a holistic one, and I can't read that, and we need effective communication. So goal setting, we need that. We work quite hard in the clinic to try and have SMART goals for every patient. And that means building up a rapport and listening. It's that listening skills of what is it they actually want, what's important to them, and what's that hook that we can get them involved in their treatment as well. So it gives them opportunity to personalise their care. It helps them with concordance and motivation. People want to be involved. It is their legs, so they want to know why they're doing what they're doing. It's much easier to persuade someone to wear the compression or do their skincare if they understand why they're doing it. It's not just because I've said you must do. And it helps us as a healthcare professional to focus on what's important to the patient. It can be very easy to look at a limb, and I think experience comes in this as well, that you look at a limb and you think, oh, I could make that so much smaller, I could do this, I could do that. But actually, what's important to that patient, and what's the outcome they're looking for? And we know that in long-term conditions, the self-efficacy is hugely important. If we don't have that patient confident in what we're asking them to do, they're not going to manage, and it's all going to fall apart. We actually don't see our patients very regularly. The way we have for our caseload is we have patient-initiated follow-up. So as one of the other speakers was saying, we need to make sure that they understand what we want them to get in touch with us about. And we encourage email or phone or any contact that we can to try and make sure that they're confident they can back touch with us at any point, but we don't chase them, that they need to do the work. They need to take control of how often they want to see us. So we know that the goals should be to their priorities and preferences. I say we need that self-efficacy to try and make sure that they're on board with us. And the other thing that I think sometimes as healthcare professionals, definitely in our clinic, we find we've got to remind ourselves, do we go back and look at the goal with the patient the next time they're in? Quite often we set goals at the first assessment, and then we sort of vaguely know that they've improved because we can see it, or they're telling their stories, but we don't actually take the time to go back and check in and praise the fact that that goal that they set has been reached. So making sure that we do check back with the goals and look again to make a new one. We need to make effective partnerships, and they need to be flexible. They need to work around someone else is saying about, what time they come in, when does it suit? Does it suit around their work? As best we can, we try and be flexible. And if their goals haven't worked and it's not been effective, well, that's not a negative problem. That's just the goal was wrong. So what do we need to do to change that? How does it need broken down more? Have we been talking different things? Because quite often that can happen. So back to compression garments, the mainstay of treatment. They enhance the pumping of action and muscles. We know that stiffness on the outside will help when we've got our muscles contracting as a counter force, so it stops the fluid leaking out so much, increases the uptake. Where we can, we use ready-to-wear garments, but not always, and in our complex patients, probably less so. And we tend to issue two. They usually last about 6 months. But again, we need to be flexible with that. And we're lucky in the clinic that we work in, we can be. So if we've got someone that's very active with a very active job, two garments might not do it. We might need to increase that. And we've got that flexibility to be able to do that. We know there's a wide range from British standard. We tend to use RAL for us. We've got class 1, class 2, all the way up. And a lot of our patients actually manage very well in just class 2. So they're not actually at that 40 millimetres of mercury at the ankle. And I'll try and explain a little bit more about that as I go on. We talk about graduated compression. And again, when you see the pictures, if you think of that last gentleman Kate showed us, graduated compression's great. That's our theoretical preference. But that's when we buy an off-the-shelf or provide an off-the-shelf garment, we're presuming it's going on a normal shaped leg. That's what it's been manufactured for. So they've got a nice narrow ankle and it gets wider as it goes up the limb. For our patients that don't have that narrowness of the ankle, then the graduation's already gone. It's not correct. So a lot of our patients, that's why they're in made to measure, because this profile just would not fit on their limb. But again, it's challenging in our heads. What do we actually mean by graduated compression? And is that the key? Or is it actually the stiffness we're looking at? A lot of our garments, we think of different fabrics, different stiffness. So, you know, the Guyanese Superman suit, that's not a very stiff garment. It's just letting him expand out into it. We think of a trampoline that's still got that elasticity into it, but it's very stiff. It's not just going to give. So we're feeling fabrics, we're thinking about them. Wraps are a stiffer property on the whole, but even when you look across wraps, there's different degrees of stiffness. So though they might have the class of compression and that they're tested to that, we might have some flexibility and different ways to approach it by going with a different fabric type that might give a different stiffness or a different amount of softness to it. So it becomes very complicated, but makes our job interesting. And I'm not going to go through this side, but these are just some of the thought process we're going before we give anyone a garment. There's a huge amount of things that are going on. And really the key at the bottom is it what they want. And I don't mean that from a, you know, I'm sure if we ask anybody, they would say, no, I'd rather not wear compression garments. But it's making sure that they understand why, and is that the best option that we can get that fits with their needs? Does it cover the right bits for them? Is it going to, can they get it off and on? Do they understand why they're wearing it? Have you made a plan? There's a huge amount that goes into our compression delivery. So I'm just going to go through some case studies just to give you an idea. I think sometimes it's easier when you've got an example in front of you, isn't it? So this is Tammy. Oh, sorry, my USB stick's just pinged at me. This is Tammy, and Tammy's quite typical of our patients that come in. She's a lady with quite a lot of superficial skin loss. Very, very wet, leaky leg. You can see she's quite heavy. And she came in for bandaging. She got our bandaging done over a course of time. Now, this would have taken longer than the normal 2 weeks. And then off she went in her below knee socks. So we managed to get the skin healed. I haven't got a picture of the skin. We're not very good at the clinic at taking the good result pictures. But she's in below knee socks. When you look at her, she could probably do with full length socks. But for Tammy, she wouldn't wear those. She finds them quite uncomfortable. She actually is now in a full length on one leg, but she found full leg socks were uncomfortable for her. She felt that she's got quite lipidematous thigh feel to them, so quite fatty tissues, and she felt they flipped. She didn't want to wear tights, so below knee socks were fine. And since then, she's not had any more recurrence of the skin loss. So again, a win for us as far as we're concerned. Not an ideal one, but yeah, it will help. This lady here, Fiona, is 54. She was well known to the clinic and was managing very well on her own, self-managed fine. She had a lot of mental health problems, so she had carers not to help her put her socks off and on, but to just go in and check on her, see how she was doing, make sure she got through her weeks okay, helped her go shopping, things like that. And they used to be in the house when she went for a shower. So she'd taken her socks off to go for a shower. Fiona liked to follow instructions to the letter. And her carer had said to her after she'd Fiona put her cream back on, and she said, well, why don't you leave your socks off and put them on later? Fiona hadn't really understood what later maybe meant, and so she'd left them off and her legs had just expanded. So then she couldn't get her socks on. Then her legs were looking a bit red, so the carer thought, oh, I wonder if she's got cellulitis. Fiona was well in herself, but her legs were red. So in she came to the clinic, and that's what her legs looked like. So say, well in herself, not particularly hot legs, a little bit of inflammation around them, and both legs were red, so unlikely to be cellulitis. So we did our 2 weeks of compression bandaging, and that's her back into her normal shape and back into her garments, and off she went again to contact us when she felt she needed us. This is a young lady who had primary lymphedema. She'd never had any input before, and you can see that her left legs were worse than her right, but she had been living with her legs like this, not really understanding why it had happened. Had never really had any input from any healthcare professionals other than, oh, you've got big legs. You can see this pitting on her right leg, but her left leg's much bigger. So again, 2 weeks of bandaging, and that's her back, and you can see the marks left from the bandaging, and that was her back in socks. And she actually wears full length compression garments, but she wears them layered. So she wears a class 2 compression with a class 1 on top of it, because that she finds a class 3 just a bit uncomfortable, and the 2 layers, and she actually wears a flat knit with a circular knit on the top of that to help maintain her legs. And then we've got Ben. So Ben is 54. He has lymphedema secondary to obesity, and it became more problematic after he had surgery on his his left knee. You can see the scar. It was OA changes. No other significant past medical history. Works full time, cycles to work, but an ongoing battle with his weight management. So he came into the clinic, and we decided, or he was agreeable to get bandaging done. So he had bandaging for 2 weeks, and you can see there that's actical bandaging. So it was padded to make a cone shape, and he felt because people were down on their knees bandaging around his leg, it inspired him to do something about his weight, and he actually became one of the Weight Watchers champions. He lost a significant amount of weight during his time at Weight Watchers, and has done well in maintaining, but you can see him there in his garments post bandaging. So he's got a thigh length one on his right, and he wears a left one that comes right up to his waist on that left leg. Again, probably not perfect, but for him, he managed to get back to his work, continues his cycling, and as I say, it was inspired to lose weight, so he's done a lot better. And this poor lady here's Mary. So Mary was a lady I met at a home visit. She had been attending a local dermatology department for years to have below knee bilateral bandaging. So she'd been going in a 2-man ambulance to the local dermatology clinic for years. But unfortunately, no one had really looked, or I don't know why, but no one had considered the bit above. And you can see that her bandaging to her knees has left her with, she has huge swelling in her medial thighs, and that's her tummy that's hanging down between. So she had got to the stage that she was finding walking difficult, and she was also getting breakage on her thighs because the fluid was getting pushed up. She was sitting large amounts of the day, so gravity was just pulling the fluid into her thighs. She does have angina, and she does have diabetes, OA knees and hips. She lives with a husband, but he works, so she's at home all day on her own, and she has a daughter and a grandson who work locally. So we did bandaging with her. I just think the next picture shows she also had, you can see there that at the back of her calf there, she's got wounds. That's because she would sit with her legs resting against the recliner chair with the base of the recliner pad bit rubbing against the back of her calves. So she had wounds. And you can see the size of these lobules just above her knees, and you can imagine how much of a restriction that caused on her knee, on her mobility. She wasn't on oxygen, and she walked with a Zimmer, you can see. So we did some bandaging and got her involved in goal setting. Mary went from someone that actually only saw her front door. She thought it was perfectly normal to only go to your front door maybe once every 2 weeks. Her mobility was, though she did go back and forward to the kitchen, she managed during the day fine. She didn't sleep in her bed. She found, because of the size of her tummy, if she tried to go into bed, she felt everything got pushed up, and that she was suffocating with her tummy. But as I say, she'd got to the point that she didn't think even just walking to her front door was a normal activity. That was a big adventure. So we set small goals about walking and she likes a smartphone. So we set step challenges, things like that. And we did bandaging. And though her shape is still not great, this is her in our garments. So she got bilateral garments on, and she was then able to put those on and off herself with help from her husband. And it gave her that bit of independence. We did a lot of going in and out to see Mary post this, though, because to try and just keep her on board and keep her on track. And she did do very well up to a point, and then she had difficult cardiac history further on the lines, and things have deteriorated. But at least for that time, she was independent and proud of herself that she could get her socks on. Elizabeth's just in here. She's a lady with lipedema. And again, just thinking of compression, when you look at someone whose leg shapes like this, and you know, one of the questions about the ABPI, you can see that cuff. Her legs are very, very tender as well. There's no way she would tolerate an ABPI. You can see she has got thread veins, which are very common in lipedema. So again, it was thinking, what garments can we get on this lady? And actually, she wears very, very soft, made to measure leggings that come just below her ankle because she doesn't have any foot swelling at all. And this is Jess. Jess is a 52-year-old hairdresser. We don't really know why she's got edema. She's been to vascular and had any differential diagnosis excluded. She's had a lymphoscintigraphy to see if it's her lymphatics that are not working well, but we don't really know. So we're presuming it's vascular. She usually self-manages, but every now and again she comes into the clinic for some bandaging. I say she's a hairdresser. So she does spend a long time with her legs down. So she knows all the tricks and tips about moving her feet, about different postures, about doing different exercises, about doing heel raises. She's a bit overweight, but not hugely so. And when she comes in for bandaging, we do compression bandages just for the 2 weeks. It brings everything back down again and she gets back into her socks. And she likes to wear circular knit socks. So she's got below knee circular knit socks that are class 2, which work for her. And she knows when to come back to us to do it for a review. This is one of my ladies that I saw. Now, she had leakage in her legs, so we were challenged with compression, and we did manage to put compression bandage. You can see that it's a co-band bandage started there. I think my problem why I tend to put this lady in is, so this lady's legs, you can see the overhang at the back of her knee. I would actually be able to get up to my elbow in that space there. But you can see above that area where she's flattened, where she sits. And she was overweight, and I'm sure has underlying lipedema as well. But the presumption would be, oh, this lady doesn't do anything and she eats too much. But actually visiting in her house was spotless. She did all her own housework. She would do it all before she sat down, but then she would sit down for the rest of the day. About a year before this picture was taken, she was working full time. She was a she was a PA in a bank. And the reason she stopped working was she could no longer fit into her car and close the door. And she cut her leg and had wound management. But it took a year before she was actually referred to lymphedema services. So the wound management was happening, but nothing about her swelling in her legs. Obviously, with legs like this, there was limited how much we could get. We did get it into garments. What we did is below knee, and then like tubes of different sort of sizes to help support the lobules in our thighs, and it did come down a little bit. But it's just difficult, I think, to think of all the healthcare professionals that she'd come across, and yet her legs had been allowed. That doesn't happen in a year. That had been happening over many years. So where are we going wrong with not getting treatment started quickly enough? And I think she's a very articulate lady who was didn't like to bother anybody, never liked to put any sort of pressure on anyone else to do anything, very highly independent. And it's always one that I remember as you sort of wonder what went wrong that a lady could get to this size. And that's me. So there's some references there. There are lots of BLS resources, and you can become a BLS member, or sorry, a friend of BLS just for free. You just need to join as a friend and you can get access to the resources. So I hope that was of interest. So thank you.
Thank you so much. Yes, it was really, really interesting. Some great comments there in the chat. Um, I think, yeah, one of the questions was around ABPI because I think as a non-specialist, people do get really nervous because it's been crammed home, hasn't it, over the years that you shouldn't put any compression on without an ABPI. And I know that there is change with that now. One of the questions was around if you manage to get an ABPI on a limb that's very filled with fluid, could that potentially give you abnormal results?
Yes, and I think that's one of the reasons why ABPI is, I think you've said it many times today already, Sarah, it shouldn't give you a surprise anyway. But in lymphedema, I think the emphasis is definitely not on the ABPI because so many of our patients, it's going to be inaccurate. So many of our patients can't get into a good position to have the ABPI done. And so many of our patients can't tolerate or have a cuff size big enough or have or tolerate it. So you're getting such an inaccuracy from it. I think it was Annie said this morning that for some of her patients as well, it's almost a case of you try it and see what happens with compression. Going cautiously, we would definitely sort of not apply over much compression to see how it goes. But I'm saying that, but in my other head, you know, as Kate was saying, if you've got a circumference as big as some of these ankles, then even putting what I would consider standard compression on, by the time it actually gets anywhere, the sort of internal structures, it's going to be so diluted anyway that so yeah, we would tend to monitor and really inform our patients, make sure, and if they are a patient with poor capacity, then we would be going in very quickly to recheck. But yet I think because of the inaccuracies, when you look at the problems or the list of, you know, whenever you do a course about APPI or go on an update and you look at all the slide that shows you the things that might give you an inaccuracy, a lot of our lymphedema patients come into that point. Yep. And we would argue that the harm would be not trying something, not getting some sort of compression on them. And say, if you look at that lady in the last slide, it's just sad that nothing was put on earlier to try before she got to that stage. Don't know if that
Well,
answers your
I
question.
was going to ask that because this just doesn't happen overnight, does it? And I know just those photographs that Kate showed us, just in that 2 years, it was bad enough sort of just as they went into COVID, but just within a couple of years, how dramatic that had become. But I think it just, I don't know what the answer is in terms of giving generalist nurses or non-specialist nurses that confidence and that sort of empowerment to do it. That as long as they've done a lower limb assessment to determine whether, you know, is there any evidence of severe peripheral arterial disease, it's given them the confidence to say, right, I can do this, I can make this decision, I can put this compression on without an ABPI. But so many trust to say no, you can't, you know.
Yeah, yeah.
And that's got to change surely, otherwise, because there are huge delays in getting people into lymphedema services because they're not you know, they're
Mhm.
small services generally, so it could be 6 months plus at least before
Yeah.
people are seen. So what do we need to do to change that so that these non-specialist nurses can do it and do it confidently?
Yeah, and I think that's it. I think days like this, you know, the sort of almost challenging some of the myths and getting that information out there. I think the problem is, as you say, and I don't quite, hopefully Legs Matter will start to challenge this as well, but the idea that often the clinician themselves thinks, yes, I could do that, but there's a trust policy somewhere
Yeah.
that says, no, you can't. And we have that a lot here, the sign guidelines in now 2015. So that's 10 years, you know, since they were done.
Mm.
And yet we still have nurses who haven't read the National Wound Care Strategy. They'll say, oh, but you know, we can't put any compression on until they've had an ABPI. But then you go round and round in this circle of, but I can't get an accurate ABPI, so then they won't do anything. And I think
Mhm.
there's documents and there's information coming out. I mean, I see the presentations today from some of these specialists who are working in really complex situations. You know, when I, you know, say that Annie and the other ones that talk talked today about in these sort of vascular situations, they're still managing to put compression on. So we do need to, it's challenging it, but how do we challenge it at all these levels? Because yeah, it's a shame. And I'd say some clinics, especially for non-cancer patients, they're waiting, I should say, well over 6 months. So we can't leave people just sitting with their limbs getting bigger and bigger while we wait for that magic number that actually should only be backing up what we found in our assessment.
Yeah, there's a question here from Ellie around when it comes to people like that last lady that you showed with significant lymphedema, when would you consider getting clearance from a specialist first? Cardio or respiratory? Could the compression affect their cardio or respiratory status? I think it goes back to that full assessment to determine whether they've got any cardiac
Yeah.
issues.
And again, you know, that we're now a bit more confident in our knowledge that even heart failure, we can put mild compression on, monitoring closely, but we can put compression on. We're not going to suddenly expect with a lady like that, we're going to get her legs down from the size they are to a normal size. It's going to be very slow anyway. But yeah, it depends on her history and what other medications and things she was on as well. Yeah, it's because we do find even with taking a history, so we ask for all that information in our referral. Sometimes it's clear, sometimes it's not. We then ask the patient again, but we also look at the medication they're on because it's amazing the number of people that will say, no, I've no problems with my blood pressure at all. But actually they do have, but it's only because they're on medication that it's stable. So we do go through a very thorough assessment, but there are very few occasions that we just wouldn't try any sort of light compression if, unless there was any of the red flags, then we would probably try compression, yes.
I think a comment by Tess is an important one around the way that skin changes secondary to lymphedema can alter colour and sometimes temperature. And that can sort of be a bit scary, you know, oh my
Yeah,
goodness, this looks, you know, arterial or whatever, and it's not, it's the skin changes
just, yeah,
associated with that. So it's about maybe, you know, having a network of support to ask those questions, which in some areas you get, you know, good
uh-huh,
support from these specialist services, and other times there's quite a delay. But that's
yeah.
a good point, isn't it, about the skin changes?
Yes, and I think as well, you know, a lot of our patients will come in with quite red looking limbs as well, or quite they'll feel that the colour has changed in them. And actually it's an inflammation or congestion rather than actual infection. If we have any doubts, then we would always ask for, you know, check their CRP, that sort of thing. But yeah, there is, and these papillomatosa, things like that can make the leg look quite odd as well. So yeah, there is, it's linking in who's your favorite, or who have you got that you've got around you that you can link in, even if it's by photos, just to say, you know, does this look okay? This is what I've found in history. But yeah, it is difficult. It's making a team, isn't it? And we all need to speak.
Yeah, and I think going back to maybe not having quick access to the specialists, I think a lot of areas are sort of developing, whether it be lower limb champions or whatever, because we all can't be really good at something. I mean, you know, generalist nurses like district nurses have to be good at so many things.
So many things.
But sort of having like link nurses or champions who have got that maybe more confidence and a bit more
Yeah.
knowledge, then they're quite a good go-to, aren't they?
Yeah, and just someone else to, I think as well, I mean, I'm very lucky. I work in a small team, but I do work in a team. So I've always got someone that I can bounce ideas off or chat to. And I think it's, so if you are working on your own, it's finding those links. Who's the person who's got an interest, so that you have got a bit more confidence once you've talked it through.
There's a comment here from Louisa, a question around, I've been told that we can apply light compression in the community for up to 2 weeks without an ABPI. Is this true? Of course, that's on the back of the immediate and necessary care. But of course, we don't want to just keep people in light compression, particularly if they've got
Mm.
lymphedema, because it really won't touch them an awful lot.
No, well, again, it depends on what your goals are. So it
Yeah.
depends what you're wanting as your outcome and what's the rest of that patient's, what they want to achieve. There are some of our patients manage very well. If you catch it mild enough and it's just edema, it's not a wound, then sometimes yes, as up to 20 millimeters of mercury might do the job. But once they get significant, like these bigger legs that there's not going to be enough of a wall made on the outside of that. You're going to have to be doing a little bit more. But yeah, it depends, as I say, what the actual outcome. These thickened tissues, 20 millimeters of mercury is not going to make a lot of a change. But a soft pitting edema, yeah, it will. It'll probably clear it for you.
Mia said around, we've been told we can put anyone in class 1. However, for class 2 or 3, they need ABPIs. Goes back to the whole thing. If you can't get one and they need
Yeah,
it,
yeah.
it's what they do.
Yeah, and it is very difficult, and I think that's that we just need to nudge the knowledge on a bit more, and get the confidence up to be able to challenge this a bit, because I do think some of these policies were written as a guideline and they've become, and we of course we want to keep our patients safe, absolutely, but sometimes we're doing more harm by not increasing the compression. And I think, as I say, some of the guidelines have become now that they're a policy rather than a
Yes.
guideline, and it's challenging that.
Yeah. There's a question here around, is it safe to apply compression if there's an infection in the leg?
So the thoughts of this have changed. Way back, I've been working in lymphedema a long time now. Way back, we used to, oh no, take it off as soon as the infection. Now we recommend as soon as that patient is comfortable. So as soon as they're started on their antibiotics, and as soon as they're comfortable and get the compression back on, put the compression back on.
Because often it's so painful, isn't it, that people
Yeah, so they might not at that, when it's really acute, the chances are that they're not going to manage to pull on a compression garment or wrap a wrap around it. But as soon as they can tolerate it, yes, get it on it, and it will stop any problems with the rebound of the lymphedema after the cellulitis.
There's a comment about, you talked earlier about the lady who would only wear purple. There's a poem about, I'm going to wear purple when I'm old.
That's right. Yeah, it's Purple
Yeah,
Hats.
that's right, Purple Hat. It's a great poem. And they were saying about, obviously, Laura knows that there's a variety of colours, but obviously it's around what's available on FP10, and the GPs won't prescribe anything that's tan or black. It's based on drug tariff, isn't it? But
yeah, and
do you
there
know
are
of anything that's on prescription that can be coloured?
Now, I'm not good with, I would need to go and look at that. I can definitely try and find out if anyone wants me to do that. But I would approach the companies. We're very lucky where we are, and we aren't bound just by prescription garments. But yeah, I do recognise that. But there are some of the companies do some of the wider range of colours on their FP10 stuff. So it's worth contacting the different garment companies and seeing what's actually out there.
There's a question. Oh, hang on. For lymphedema legs with lower leg wounds, would you recommend thigh length compression? I suppose if their wound is on the lower leg, but they've got, I suppose it's whether they've got oedema above the knee, isn't it? I suppose.
Yeah. So I think you want to contain above the edema. So if the edema is coming onto the thigh, then full length, yes. Or if it's coming high, if it's just at the bottom part of their leg, then probably below knee is fine. But if it's coming up towards the knee, then thigh length preferably. And it's amazing how many people shy away from thigh length, and actually because they say, oh, they'll be too difficult to get on, but actually getting it over your foot's the hard bit. Once you've done that, you're on a winner. So you'll be able to get a thigh length on. But again, it will just depend on where the edema stops and where the wound is.
And just finally, just if you could just clarify for people around the best hosiery, because there's a question here around British standard and of course RAL or European, and what's best for lymphedema.
Yeah, so in lymphedema, we tend to use RAL, just because it's tested to the appropriate amount, and that's what we tend to use. But we will use, again, it's individual, so it depends on that person. But I think the main thing is that we all talk the correct language. So if we're using British Standard Class 1, it's actually better to talk about the millimetres of mercury rather than we all do it. And I probably did, and I apologise if I did. We talk about Class 1, Class 2, but actually the millimetres of mercury is what's important, and the static stiffness index will start to become more obvious. They don't put that on boxes at the moment, but how stiff a garment is quite important as well. So it's describing what type of garment you're using from the fabric, but also the millimetres of mercury.
Brilliant. And that's, yeah, I think I'm sure have looked at every question, but if not, maybe we'll have a quick skim and you could answer it offline. But thank you so much. That was a fascinating presentation. Lots of information for people to take on board. And yeah, thank you for giving up your time to present again.
Thank you very much for asking me.